Myself, Swami Sankalp Sani, the marketing manager from Innovcare Life Sciences. Welcome all to this interactive show, the Pundit at Dr. Ritu show, supported by Innovcare Life Sciences. Today we have a very special guest on our show. She is the teacher of the teachers, Dr. Sonia Malik. Welcome, doctor. It's important for us to understand what makes Pundit show unique and special. It's a knowledge sharing platform for experts as well as young doctors. The perfect mixing and mingling done by Dr. Ritu when it comes to strike balance between basic questions and advanced questions. Not only from India, but doctors from across the globe are getting benefited from this show. This show has covered all aspects, be it gynecology, obstetrics, sexual wellness, women's health, legal aspect, and others. With this, I would request to introduce our special guest, the teacher of the teachers, Dr. Sonia Malik. Over to you, Ritma.
Yeah. Thank you, Sankalp, and good evening to all dear friends who have joined from India and across the globe. A very warm welcome to all of you in this show. Friends, I think all of you agree with me. The reason of the success of this show that this is a pure knowledge sharing platform. So I believe that knowledge is the key to success. With this motto, I will keep on inviting the fraternity, the experts from our fraternity who also believe in the knowledge sharing. I am here, your host, Dr. Ritu Santmani, Director, Pune Test to Baby Center from Pune. Our today's guest is very dynamic, charismatic personality, teacher of teachers, Dr. Sonia Malik, madam. Madam, a very warm welcome to you.
Thank you, Ritu. Thank you so much. Hitiro.
Thank you, ma'am. Thank you so much, ma'am. Vaibhav, can we have the ma'am's biography, please? Yeah. Ma'am, Dr. Sonia Malik, ma'am actually doesn't need any introduction. Ma'am is very popular, very humble teacher of teachers. Ma'am is DGO, MD, FICOG, FIMS, Director and HOD, Southern Fertility and IVF. Delhi. Ma'am has so many positions: past president, IFS Society, chairperson, Infertility Committee, FOXY 2014 to 16, past president, Indian Menopause Society, associate editor, Southeast Asia Journal of Global Health, IFFS, member editorial board, Fertility and Sterility India, member editorial board, Journal of Reproductive Health and Medicine, editorial board, Journal of Fertility Science and Research, past editor in chief and Journal of Midlife Health, scientific collaborator, Reproductive Research Center, Cleveland Clinic, USA, member of ICMR Task Force on Genital Tuberculosis. Ma'am has so many awards: IMA Kanak Goyal Award 2007, IMA Lifetime Achievement Award 2015, ACE Lifetime Achievement Award 2019, Haryana OBGYN Lifetime Achievement Award 2019. So, ma'am, a very warm welcome on the show. Ma'am, before we start, ma'am, before we start the show, ma'am, we want some tips from you. We all see you as a role model. So we want some tips. Please give some tips to the young budding gynecologists.
Ritu, thank you so much. First of all, I must thank you for this invitation. And I must also congratulate you for this very innovative program that you have set up and has been going on so successfully for the last so many months. I would also like to congratulate the team of Innovcare for supporting you and for supporting all of us to be able to, share our knowledge. As you said, this is a knowledge sharing platform. So this is an unusual concept which you people have actually put together. And I think it is helping people who are joining with you. And I believe you've had great numbers who have come and attended this show, which speaks volumes of what you all are doing. So congratulations once again for the success of this program and for all your efforts.
Thank you.
My advice to the youngsters and people who are listening to this, I have always believed that, you must believe in yourself, first of all. Whatever you have thought for yourself, whatever your goals that you have set for yourself, you have to be true to them. You cannot keep on meandering from one route to another just to achieve something. Try to set a goal for yourself and go straight towards it without many deviations. Because if you keep on faltering, looking at this side of it and that side of it, it becomes very difficult to achieve what you have thought for yourself. So that is one. And the other thing is that please do not ever forget the ethics of your practice and the ethics of your knowledge. It's very important to be extremely ethical in this unethical world, I would say. We know that there is a lot of challenge when you try to be honest and ethical. There are lots of challenges. Even the patient sitting in front of you may subject you to a situation where you tend to become unethical. But remember that always, that the patient sitting in front of you could be your sister, she could be your daughter, and she could be anybody related to you. So treat her like that. Try to put some sense into her and never be unethical. Honest to you, honest to yourself, and honest to your profession, honest to your subject. Uh, if in the subject of fertility and infertility in the country is basically mainly dependent upon your own conscience and your own feeling. The country does not need too many people. It's basically the individual couple who comes to you has come to you with a desire. That she has not come to you with a disease. She's come to you with a desire. And it is up to you and her to join together and try and fulfill that desire. So, whatever you do has to be done with a clear conscience, honestly, and be so honest to her as well as to yourself that she comes back to you again even after she fails. My biggest compliment to myself is when my patient comes back to me after failing in IVF. That she has the confidence in me, she has the confidence in in our way of tackling the problem. She's understood that everything is not possible, and so she comes back again with the confidence, saying that okay, it had to happen, it can happen, we will be successful. So I think that is the biggest compliment to you when your patients, even after failure, come back to you. So remember these things, and I don't think I have much more to say. But with this, and please keep on upgrading your knowledge. So as Ritu has
Right.
given this wonderful platform to all of us, it's very important to actually share also. Whenever there is a failure, don't feel scared to share it with a friend. If you have a problem, share it with somebody, because basically sharing means increasing your knowledge and your outlook towards problems. Therefore, with that you will become wiser, and maybe you are able to treat your patient better in the next time when you are a little more aware of other people's problems also. So I think, Ritu, I think I've said enough.
Yes,
It's
yes,
a lot.
yes, ma'am. Thank you. Thank you. Thank
Yeah.
you. Thank you so much, ma'am. Ma'am, tell me one more thing. What motivated you to become a doctor and especially a gynecologist?
Oh, well, sometimes what happens is some events during childhood stick to you, and they kind of form the basis of what is going to happen to you in future. I remember I was a very small child of 6 or 7 years old, and there was a patient downstairs in the neighborhood, and we were uh, we used to go and see the patient off and on. She was not, I mean, a neighbor's mother, and I went there and I saw that they were believing the Jyotshi more than the doctor. Each time I was 7 years old, remember,
Okay.
I wasn't even old, but
Okay.
I saw them believing the astrologer all the time, and science meant nothing to them. And I would come back and question my mother and ask her, why is it that they do this? And she would say, that is why you need to change the scenario in the country. Probably you need to do something to make them understand that this is not the right way to handle disease. It has to be scientifically handled. So somewhere that stuck to me, and I kept on working towards this goal of becoming a doctor. And it actually, I'm sure my mother would be proud of me. She was. And when I was
Right.
finally able to achieve what she had said to me at that time. So I suppose small things, small incidents in life change your way of life completely. So that's how it started. Yeah.
Okay. 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 Thank you. Thank you. Thank you so much, ma'am. So, ma'am, today all of us are eagerly waiting to listen your lecture. We have got so many already requests when I announced that Sonia Malik Madam is coming with such a great topic. Before you take the lecture, already I got lot of appreciations that all want to listen to you, ma'am. So, without wasting much time, ma'am, over to you.
Thank you so much, Ritu. I hope I can do
Yeah,
justice to what you people have been saying, but nevertheless,
of
I will
course,
share my
ma'am.
screen with you.
Yes,
Uh,
ma'am. Yes, ma'am.
I think you have to allow me to share the screen. Oh yeah, there it is. Yeah,
Yes, yes,
1 minute.
yes, yes, no problem.
Okay. Okay, so today we are all here to talk about what is new in ovulation induction protocols. And basically, this is kind of a very basic subject, and it forms the basis of what we are doing in ART practice. How to induce ovulation in patients who are anovulatory or have this dysfunctional ovulation. So let us see how we have progressed over these years, these couple of decades. So it was way back in 1958 that Kistner first introduced the term ovulation and basically induction of ovulation, and it became the standard treatment for all ovulatory defects. However, it was in 1978 when Steptoe and Edwards did some pioneering work, and we had the first test tube baby of the world. However, we were not far behind, and ICMR recognized our own IVF baby in 1986. But uh, till today, ovulation induction remains the basic fundamental part of our treatment. And of course, the term should be restricted to mainly ovulation induction in order to achieve a single dominant follicle, resulting in the release of a single oocyte and finally a singleton pregnancy. But nevertheless, when we are talking about ovulation induction in ART, we also have to consider ART in terms of IVF, where we are actually producing many more eggs. Let us take a look at the female reproductive system, and what we understood of it was that there is a release, there is an ovarian cycle, and that is actually under the control of the pituitary, wherein the follicle forms, and then there is a release of the egg, and finally the corpus luteum, under the effect of which the ovarian hormones are also being produced. They basically have an effect on the endometrium, which changes, as you all know, from proliferative to secretory phase, where it is decidualized, and finally implantation happens. So this menstrual cycle, I think, is absolutely, we all know from the back of our hand, and we are kind of ruttoed in it, and so we are perfect in it. However, in 1976, WHO gave us this classification of the three types of dysovulation: the group 1, which is the hypothalamic pituitary failure, group 2, which is the dysfunction, and group 3, which is the hypergonadotrophic ovarian failure. So we had three classes of women: the group 1, which had pituitary failure and basically lacking in both FSH and LH, and the group 2, where there was a dysfunction of the ovulation, and then finally where there was a failure. So essentially in preclinical practice, this is the largest segment of women that we are dealing with in day-to-day practice. But nowadays, this third group is also on the rise, and we are seeing more and more women falling in this group. So that was the classification, which has still stood the test of time. And we looked at the various possibilities of ovarian stimulation by stimulating the hypophysis and then stimulating the ovaries, and also acting to a certain extent upon the hypothalamus. So these were the various classes of drugs which were introduced, and we had a long list of them. And what we understood was that there is a window of stimulation, or the FSH gate or window as it is called, and every month, because there is the production of a dominant follicle, because it falls in that the FSH level falls within that window or the gate. And if we want to produce more than one egg, then we either increase the amount of FSH that we are giving, or you increase the duration of FSH that you're giving to the patient. By doing each of these two things, you can increase the number of follicles that you're getting, because you're increasing the amount of FSH that is going to be available to the woman in order to form more follicles or form more eggs. So hence, this window, the FSH gate, became very, very important, and we were not giving so much of importance to LH at that time. So basically, the concentration was to work on the FSH and to increase that somehow or the other. So the drugs that we were using were the anti-estrogens, the gonadotropins, and of course later on the GnRH analogs as the antagonists and the agonists. The agonist came first, followed by the antagonist. All this is history, but I'm just recapitulating it with you all. We had these conventional protocols, and of course we knew that there was something called hyperstimulation. Therefore, we were considering soft protocols. The goals were basically primarily during those times were to produce many oocytes and prevent a premature LH surge, and also to prevent ovarian hyperstimulation syndrome. Therefore, all the protocols were directed towards these three goals. We were producing many, and we were trying to prevent OHSS. This became our standard protocol, the OCP pre-treatment long protocol, wherein you start the OCP either from the second 7 to 8 days prior to the ovulation or on cycle day 1. Then you go on with the agonist, and then you start with the FSH either on generally on day 3, not on day 1 now, and you keep on individualizing the protocol. Again, the second one was where the agonist would be reduced once the period started. In some people were actually using the same dose of GnRH agonist, but the others were reducing the GnRH agonist once the downregulation was done and the period began. So this was the variation between the agonist protocol in those days. The short protocol, on the other hand, was at that point of time started only to reduce the amount of FSH to be given and to produce a kind of a bolus over there, a flare effect. As we all know that GnRH agonist produces a flare effect. So it was basically to produce a flare effect and also to continue it till the day 14. GnRH was continued till day 14 so that it prevents the premature LH surge as well. So it was a dual advantage, a short flare followed by a downregulation in order to decrease the number of ampules of gonadotropins and to prevent an LH surge. The ultra short protocol was only to use the flare effect, where it was given for 3 days, and then it was a conventional protocol. The disadvantage of this protocol was that there was no cover for a premature LH surge. So this is a comparison of all the protocols that we were using at those days: GnRH long, GnRH short, and ultra short. We are also still using these protocols. It wasn't as if we were using it then only, but we shall come to our change in protocols now. The thinking has changed. So again, in severe endometriosis, we were using this extra long protocol where we were giving 3 doses of agonist each every month. Every month we were repeating the agonist and then starting the recombinant or the normal FSH after 4 weeks. And then we realized that in order to prevent the ovarian hyperstimulation, we had to do some jugglery to the gonadotropin. Otherwise, patients would land up in hyperstimulation. And we started using either the step-up protocol, wherein you start with a small dose and keep on increasing it individually depending upon the response, or you start with a higher dose and then step down depending upon the response. This was still a little more difficult because it would not actually prevent the hyperstimulation to such a large extent as the step-up regime. So this came to be using the low-dose step-up regime became our pet protocol, especially in patients of PCOS. So the chronic low dose, like I said, with the starting dose, which was 37.5 to 75, then you do a scan and you keep on increasing the dose by 50% till you get a leading follicle of not 16 but about 18 millimeter, and then you give a trigger. So this became our standard protocol for many, many years. And then came the antagonists. So with the coming in of the antagonists, we got to know that there was another GnRH analog, which was very, very effective because it was absolutely causing a down regulation directly without any flare effect. And hence there were various protocols which were introduced. One was the single dose antagonist protocol. A single dose of 3 milligram was given, and of course, it was continued the same way. This was not very popular. Then we had a multi-dose antagonist protocol where we were giving it daily, and we are still using. This has now become the standard treatment in most IVF units where a multi-dose antagonist protocol is being used in majority of the centers. Then there was a third one which was also promoted, which is the fixed dose protocol, where you start the antagonist on day 6 of the cycle, or sometimes in PCO in day 5, when you are expecting a very quick response. So in that case also, you can start it on day 5, and this is continued till the HCG injection. This also has gained a little bit of popularity, but in India, in majority of our centers, it is the multi-dose GnRH antagonist protocol, a flexible protocol, which is being used by most IVF units. Now, there has been a sea change, therefore, in the understanding of the reproductive physiology now. What has happened in the last 10 years is that we have understood that there is a finite number of oocytes. We don't have so many. And every oocyte does not have the capability of producing a pregnancy. Very important to understand. We may be producing 10 eggs, but every egg is not going to result in a pregnancy, and that the endocrine manipulation can be done throughout the menstrual cycle. It is not restricted to just the follicular phase. We can do it even in the luteal phase. So this is what we have understood now over the years when we are doing ovarian stimulation, and that stimulation can be started at any given time in a menstrual cycle. But every individual behaves differently based on many factors, which are both extrinsic and intrinsic. This is very important because this is what has led to ICOS, or individualization of controlled ovarian stimulation. So in order to form an embryo, what do we need? We need a very good oocytes, we need sperms, we need high-tech labs, and we also need genetic screening. This is the new thing which has been added to our armamentarium of ovulation induction, because the aim is to produce a child. It's not just to produce eggs. We have realized that we have to give a healthy child, and therefore we need to produce the best embryos. And what do we need for that? Basically, we need just one golden egg in order to produce. So, but how many eggs do we need to produce only one euploid embryo and a live birth? That is now the biggest question that comes to our mind after doing so much of jugglery all these years. And you all may be aware of this very large database from UK, which was published a couple of years ago, and it says that you are essentially, the magic number lies somewhere here. 15 eggs are actually required to give a very good oocyte, very good pregnancy rate. As you can see over here also, that if you have about 15, you have a very good cumulative pregnancy rate and a live birth rate of 61.5%. And the OHSS is also not much, it is about 4.1%. This is a study not very many years ago, for about 2016. And you can see over here that if the number of oocytes is about 15 or little above that, then 15 or 16, then it leads to about 62% pregnancy rate. So which is a very healthy live birth rate. And then what is the optimal one needed? So again, in order to produce one live birth per cycle, again the magic number comes here, somewhere here. So therefore, in order to have a good index live birth, good live birth, the magic number is about 15 to 16. And this came later on. This is another very good slide and very good study for all of you to take. And if I wouldn't mind you taking a picture of this, because you can counsel with this, you can counsel your patients with this. Remember, if the age of the patient is around 35, she needs 6 COCs in order to have one euploid blastocyst. But the same woman, if she's 42 to 43 years, she needs 18 eggs at least in order to produce one euploid blastocyst. So remember that the number of eggs that you require to have one healthy child is going on increasing as the age advances. And that is our biggest problem, because as age advances, the number of eggs that the lady is going to produce is going to be decreased each year. And how are we going to get this magic number to get this one euploid blastocyst is our challenge and struggle. That is what we have to actually look into. And you know that the effect of age is tremendous. You know that not only is the number of egg, but also the euploides and the aneuploides are increasing. The aneuploidy is increasing and the euploidy is decreasing. So the implantation failures are increasing at age 40 to 44. Spontaneous miscarriages and affected children are also are definitely much more at a later age. And interestingly and sadly, we know that in India, we are aging 5 years in advance. Majority of our studies are saying that. Hence, if in Europe, a 44-year-old lady is producing this kind of a result, we would have the same at about 40, 41 years. So remember, there is a gap of about 5 years as far as outcomes are concerned. And what you would counsel a woman of 40 would be what a European would be counseled at 40 or 44, 45. So remember that there is a huge ethnic difference in the production of the good oocytes that you are going to have. Again, this is our own data suggesting the same thing, that if the lady is about 30 years of age and if she has a good good AMH, then the pregnancy rate is good. However, if she is 39 years or above, I said 40-year is going to behave like that. Look at her pregnancy rate. Fresh transfer is only 3.7%, but frozen transfer could be about 5%, not much difference. And if you can see here, the numbers are very few. So therefore, what I'm trying to tell you is that basically as the woman ages, this magic number keeps on falling, and that is what is our biggest challenge. And again, the same holds true for all the age groups. It's not that it is at 25 you're not. The most important thing that we have to remember is a higher aneuploidy rate in older women, irrespective of the embryo number. And similarly, a higher number of euploid embryos will increase the cohort size, will increase with the increased cohort size. So if you have more embryos, you will have probably more euploid embryos. But if the lady is older, then the number of aneuploidy is also going to be is going to be more. So remember, age and number are two things which you have to really bother about in patients now. And then, what is an impaired response? The impaired response is where, of course, we are aiming for a good live birth rate, but we are also aiming for a decreased OHSS rate. And this is somewhere these two lines are meeting, as you can see. So if you have lots of eggs, okay, the number of eggs is more, the embryos would be more, but the OHSS is also going to increase, and the live birth therefore is not going to change very much, because basically with the complications there may be a lot of miscarriages, and therefore the total number of live births will be decreased. Hence, if we are basically looking at good stimulation, what do we have to do today? What are our goals? Our goals have now changed. We have to maximize the efficacy, and we have to give a good live birth rate. We have to reduce the complications and risks, which we were trying to do earlier also, but we are much wiser now. Cycle cancellation has to be looked into all the time. We also must look at the treatment burden for these patients, and of course beware of the complication of OHSS all the time. So even though you may want to desire to make the whole thing very, very good and very robust by increasing the number of eggs that you are producing, remember that you're also increasing the risk of complications. Therefore, a good balance between the two has to be arrived at, and your stimulation should be perfect like that. So therefore, an optimal stimulation has to be effective, it has to be safe, and of course, it has to look at the cost as well. But what are the factors then which depend upon which are so important for us? So some of the patient factors are the age of the patient, which we have talked about, the number of years of infertility. Suppose she's been married for a long time, and here is a woman who's just married for 2 years. Her fertility rate is definitely going to be better. Type of infertility, cause, the phenotype within the disease. And for instance, you may have a severe endometriosis, and you may have minimal endometriosis. You may have a classic PCO with all features and phenotype A, or you may have a ovulating PCO. So depending upon what the disease is, the phenotype within the disease, and previous treatment history, all these factors are those of the patient. And also, what about the physician, where is your role that comes in? So physician dependent factors are definitely how you handle this patient, type of gonadotrophin, the dose of gonadotrophin, the regimen, the type of ovulatory trigger, the luteal support, and the administration of adjuvants if you are going to give them. So basically, it is a huge responsibility and a role of the physician as well. It's not just the patient factors. Optimal stimulation, therefore, is to avoid understimulation, to avoid overstimulation, minimize cycle cancellation, and minimize, if not avoid, complications like OHSS and multi-order pregnancies, both. We don't want to give her a triplet. So again, we come back to the same thing now. But what has happened to this ovarian ovulatory dysfunction classification now in this decade? We now have something called an ovarian response within each group. And this is very, very individual. So even if the patient is hypothalamic pituitary failure, and if she's old and she's coming to you at age 38, we are going to have a problem in stimulating her. She is compounded by becoming a poor responder as well as a hypothalamic pituitary failure. Similarly, if in the group 2, that is the hypothalamic pituitary dysfunction, here again, a PCO, like I said, the ovarian response is going to be different for different PCOs, different for different kinds of endometriosis, different for pelvic inflammation, and of course, you have a huge group of ovarian failures, which is group 3 to stimulation and the protocol for that particular patient. So now our challenge has increased because we have further identified the types of patients that we are trying to deal with. And what is now the phenotype of response? We have 3 kinds of responders. We have the hypo responders, we have the normal responders, and we have the hyper responders, the 3 types of responders. So, and all the individualized ovarian stimulation protocols are based upon 4 parameters of ovarian reserve testing. That is the age of the patient, which we have discussed, value, the age, and the just a PCO, but even otherwise, we all know that obviously, as such, indicates a poor response in any patient. So therefore, these are some of the factors which you really have to have to look into in order to know how you have to stimulate your patient. And now, also, another big factor which we need to understand is a previous response of the patient if she's had a previous cycle, because all these factors are actually going to help you to determine how you're going to stimulate this patient in this particular cycle. So what is a hyper response generally? A young age patient with an AFC of more than 20, AMH of more than 3.5, PCOS, and the objective here is to prevent ovarian hyperstimulation. A normal responder, on the other hand, would have about 5 to 18 follicles, AMH of 1.2 to 3.6. Now, these values vary for various guidelines that have been given across the period of time, but these are some of the generally followed guidelines. And then there is hypo or poor responder, where an AFC of less than 5 and AMH of less than 1.2 is considered to be the factor. So how do you choose your protocol? Depending on that, we all know that if you're anticipating a high responder, you have to start with a lower dose of gonadotropin, and the GnRH antagonist protocol is the standard protocol for them, because normal oocyte yield will happen, and there will be there is very little risk to ovarian hyperstimulation, and we will need to cryopreserve these. If the patient is a normal responder, you can give any of the 2 protocols, whether it is an agonist or an antagonist protocol. And here again, the aim is to optimize it and reduce the cancellation and ovarian hyperstimulation if it may happen even with a normal responder. In a poor responder, on the other hand, the antagonist strategy with a short stimulation and will need to moderate type of cancellation. So here the dose is higher as compared to the others, but we will come to this a little later on. Based on the ovarian reserve testing, there have been many protocols which have been, or many models which have been set to actually guide us to this dose that we have just talked about. The popular ones are Povovic, the Howells, La Marca, which of course is very, very popular now, and that is what we are following: age, day 2 FSH and AMH, and the pivot. And based on these, we are actually, these are acting as our guidelines to understand what dose of gonadotropins to give to our patient. And this, you can refer to this chart and see if the total number of follicles, ovarian volume, total Doppler score, age, etc. are there, then you can base your FSH depending upon these scores. Similarly, then, what about the hyperresponders? The challenges in this kind of patient is basically two: increased risk of cycle cancellation, and we have to prevent a premature LH surge, and we have to prevent the OHSS, like we've been saying all through. So the preferred protocol here is OCP during the or luteal phase GnRH agonist, as in the long protocol, a low dose FSH with minimal or no LH. And the GnRH agonist is stopped once the patient gets a period. This is called the stop protocol. And the GnRH antagonist has started from day 6 of stimulation, could also be started from day 5, as I said. And then you give the GnRH agonist trigger with a luteal support with progesterone and estrogen if required, but estrogen doesn't seem to be making much of a difference. You may either transfer a blastocyst if you think that the patient is not going to go into ovarian hyperstimulation, or else you freeze everything. What happens to the poor responders? As you all know, there is a very nice stratification called the Poseidon Stratification now, which actually classifies the poor responders into these 4 groups of patients with poor prognosis. So the group 1 and 2 are essentially patients where there is an unexpected poor response. You were not thinking about it, but it happened because the AMH and the AFC was within normal limits, and yet she did not respond well. Group 1 is below 35 and group 2 is above 35 years of age with an unexpected poor response. Group 3 and group 4 are patients with expected poor response. Group 3 would be patients who are younger than 35, and group 4 would be patients who are older than 35. So these are the 4 groups. And actually, it is these 2 groups, the group 1 and group 2, which actually give us a surprise. And that is why, if there is a history of earlier IVF, it is very important to know what the stimulation was like and what was the outcome, because we may want to do something here in order to make the patient pregnant. And group 3 and 4, of course, are really, really difficult. Hyperresponder is another definition now, and this has been set for patients in the group 1 and group 2 where the number of oocytes is between 4 and 9. So basically the response is there, but it is not what was expected, but it is not poor also. So these are hyperresponders, and again their ovary doesn't seem to be having the same follicular output rate, or FOAT as it is called, as we would want it to happen. So patients who are actually showing a good AFC and a good AMH, but their follicular response is not adequate, are actually patients where they have a poor follicle output rate and are labeled as hyporesponders. What then are the therapeutic options for these? These groups, the group 1, which is basically a young girl, actually it is said that if you add LH to that, add to the RFSH and increase the starting dose of FSH as well, then you get a better response. And most of these people are those who have some kind of a polymorphism of the FSH, therefore the response to it, or polymorphism also to LH, and therefore the response to stimulation is not as adequate as it was supposed to be, especially the ones who are the hyperresponders. So therefore, in these patients, if you add LH to the FSH, then the response becomes better. So this is basically what I'm trying to tell you, that there are basically some of these patients who have polymorphism, and hence if you increase the dose, you may get a better cohort. Similarly, in group 2, again, the unexpected poor responders, here again, it is basically the effect of age and decreased androgen production, which may be leading to this. So the therapeutic options are again to increase the dose and to add LH to it, or you can do a dual stimulation within the same cycle. I'll describe this a little later, and therefore you increase the total number of oocytes and the blastocysts that you're going to get. So what is a dual stim? Basically, what we have realized over a couple of years is that there are not just one wave of folliculogenesis. There are many waves of folliculogenesis happening in women. Different women behave differently. These may be two, or these may be three even. And so if you stimulate the patient maybe once and then twice during one complete menstrual cycle, you may be able to get two cohorts of follicles, and therefore number of oocytes which you will retrieve will be much more. So based on this premise, what is started is called a duostim, wherein you start in the same way from the third day of the cycle. You give clomiphene or letrozole. We generally prefer letrozole, we all know that. And with that, you start the gonadotrophins. You do give a GnRH agonist trigger, and you do the first oocyte retrieval. 3 or 4 days later, you wait for the corpus lutea to decrease in their size. And then 4 days later, you start with your second cycle, and you start in the similar manner. You keep on giving the gonadotrophins, and you do a second retrieval. So majority of the studies say that the first and second retrieval nearly give the same number of eggs, and therefore your total cohort is increased. So basically, then here is what I was telling you. It generally, data to date shows that double stimulation in poor responder provides a shorter time for retrieving mature oocytes with the potential formation of good quality embryos and thus healthy pregnancies. So therefore, it is kind of advocated in patients. However, I will come to the evidence a little later. Group 3 and group 4 are patients who are poor responders, and very little therapeutic options are there for these patients, and therefore we can either offer them donor eggs, or we can even do a dual stimulation for these and keep on collecting their eggs. There is also something called as oocyte collection. Here what you are doing is you are doing a minimal stimulation with either clomiphene or letrozole, and and a little bit of gonadotrophine. Give 1 or 2 injections of antagonist in a modified natural protocol, letrozole, HMG, antagonist, and HCG trigger, to an OPU, and then freeze the oocytes. Do multiple cycles of these, and then do an ICSI and ET in some of them. These are especially this kind of protocol, ACUVIT it is called. Means that you stimulate, and then you just keep on collecting the oocytes, and therefore this kind of a protocol is used in most of the Muslim countries in the Middle East, because their donor eggs are not allowed, and the people do not want to resort to donor egg IVF. Hence, they keep on stimulating these patients and collecting the eggs. What are then the new additions? What extra have we gained after learning all this? Now, number one, we need to see the evidence for these non-conventional start of ovulation stimulation in patients who are normoresponders. The ovulation stimulation for fertility preservation. What is the difference in the triggering of ovulation now? Is there a difference in the luteal phase? Are we preventing it with OHSS, and are there any new drugs? So first of all, random start protocol, like I said, is something which was actually started for fertility preservation patients, but it can also be done for any kind of patient, especially if the patient is in a hurry. But however, ESHRE 2019 guidelines says that the evidence is very little, and most of the eggs will need to be frozen, because this is basically, the endometrium is not compatible. So a higher dose of FSH could also be required. Hence, keeping all this in mind, a random start protocol is not advocated for routine patients in IVF. Similarly, late luteal phase start of gonadotrophins, which is advocated with antagonists, is also not recommended for low responders. Early luteal phase start of gonadotrophins is probably also not recommended for normal and low responders. And luteal phase stimulation could be used in non-transferred cycles, of course, but it is not recommended. Why? Because the justification is that there is not enough evidence to say that it is beneficial, number one, and the economics has to be considered, and the effect on the offspring is not yet known. We do not know. All these protocols are very new, and therefore we really do not know what is the effect going to be on the offspring, although the effect on the oocyte doesn't seem to have been affected. The other negative point is that freezing always has to be done, and so the economics of the whole protocol has to be considered and told to the patient before you begin any such thing like a late luteal start or an early luteal start of gonadotrophins. Similarly, the dual stimulation that I told you can be done only in urgent fertility preservation cycles. Otherwise, it is not recommended. Now we come to the second new thing that has come into the anvil, and that is fertility preservation. Here again, random start, duostim, everything is actually advocated. This justification is, although the evidence for the utility of these protocols is still lacking, but the justification is that these patients are actually uh, going in for cancer therapy and they have very little time. Therefore, we need to help them and do it as fast as possible. One. And the second thing is that the antagonist protocol is actually supposed to be more beneficial because there is no difference in the outcome between agonist and antagonist. And the antagonist protocol is actually preventing ovarian hyperstimulation because we can give a GnRH agonist trigger. Therefore, this is the preferred protocol. Also, there is a higher risk of thrombosis in these patients. Hence, we must be very careful that they do not go into any such state as OHSS. Therefore, the antagonist protocol can be started as a random start protocol in these cases. Again, random, this is justification for that. And then the other thing is that basically, should we be giving anything like an anti-estrogens to these patients? The evidence again for giving estrogens in drugs like tamoxifen, letrozole, and clomiphene in such patients during this fertility preservation is actually a query, because we do not have much evidence to say whether it is going to be helpful or not. But in view of the fact that they are actually decreasing the estrogen level in these patients of breast cancer, it is advocated that we can use them, and along with that we can actually give a GnRH agonist trigger. So therefore, they are not detrimental but supposedly producing some kind of a usefulness in such patients where you're doing fertility preservation for cancer. What about the trigger then? What are the changes and the new thoughts in the trigger? We all know that we have been using HCG as a surrogate marker for the LH surge, and that has been the standard practice. And you all know that the surge that it produces is longer and it lasts for many days as compared to the natural surge. However, the downside of this was always that it produces OHSS, and therefore came in the GnRH agonist trigger, which is a very surge, and it lasts for a very short time. Therefore, just 20 hours it is lasting. It rises fast and comes down fast. It's not like the natural surge, and it's definitely not like the HCG surge. Therefore, it doesn't produce OHSS. But then what is the difference between the two? So within HCG, the LH activity deficiency period is smaller because the HCG is there in the body for a longer time. In the GnRH agonist trigger, because it is a very short surge, therefore the LH deficiency period in the luteal phase, and therefore corpus luteum support is deficient in these patients who are triggered with GnRH agonist. So therefore, when you are using the GnRH agonist for any of your patients, you have to give a very, very good luteal support versus HCG, where the luteal support is to a certain extent there because of the HCG itself. So the comparison between the two definitely is that it stimulates the LH. Here it is more physiological. It stimulates both an LH and an FSH surge. Therefore, the maturity of the eggs is supposed to be better as compared to this one. And then its half-life is longer. Therefore, the action lasts longer. Here it is sharp. Luteal support, therefore, is better, but here it is deficient. And here the major factor is it causes OHSS, whereas OHSS is rare in this. So the definitely with GnRH agonists, even the meta-analysis and a Cochrane review of 2009 states that GnRH agonist triggering is definitely beneficial because it reduces the OHSS. And the early luteal phase after ovulation triggering is definitely different compared to, it is negative as compared to the HCG trigger. So therefore, we do need to do something about the HCG, so about the luteal phase. So how do we support these? There are two thoughts to this. One, of course, is by giving an HCG or a dual trigger, where it is used to supplement the deficient luteal phase by improving the pregnancy rate, and various protocols and different timing and doses of HCG have been advocated. So here are some of the RCTs on the GnRH agonist trigger and LPS for fresh ET. And as you can see here, by adding This is just progesterone. And here you can see that the miscarriage rate is 79% and the clinical pregnancy rate is 6%. Whereas if you add anywhere HCG on the day of OPU, HCG OPU plus day 5, or a low dose HCG all through during OPU, you find that the pregnancy rate increases, it shows a very big jump, and the miscarriage rate here, it even falls to about 9% when you're giving 2 doses of HCG, one on the day of trigger and one after 5 days. So you can see here that the miscarriage rate, but then the risk of ovarian hyperstimulation still remains, and you have to be very careful, very judicious when you're using any of these protocols. Then there was another thing that has come up, and that is called a double trigger. A double trigger was first proposed using 4 hours apart in order to improve the maturation of oocytes and thus increasing the number of M2 oocytes. So remember, there is a difference between a dual trigger and a double trigger. A dual trigger is when you're using HCG and GnRH agonist in order to help in the luteal phase. It is acting to majorly because you want to improve the luteal phase. However, a double trigger, when you're using these two, the GnRH agonist and the and the HCG 4 hours apart in the same cycle in poor responders or in very, very severely downregulated patients to improve the maturation of oocytes, in such patients, this is called a double trigger. So what was found was that the LH, if you are giving a GnRH agonist trigger, and if the LH does not rise after that, the surge is not happening, then basically the number of eggs that you retrieve is much less. So in order to increase the number of oocytes and to increase the maturity of the oocytes, it was suggested that you give another trigger of HCG in order to get a better cohort. And the indicators for giving this are basically a basal level of LH, which should be more than 2. And basically, after 12 hours, if you do an LH level, it should be more than 15. This was the protocol which has been proposed by Haas et al., where you, depending upon the serum LH at 12 hours, you decide what kind of, if it is 15 or below that, then you actually, nothing much has to be done. But if it is less than that, you have to again give a HCG trigger. So the outcomes, as you can see, this is a very recent study of 2019. It tells you that the clinical pregnancy rate, the live birth rate, everything improves if you have given a GnRH agonist and an HCG trigger in order to improve the outcomes of the oocytes. So again, therefore, the luteal support will definitely vary according to the response to the stimulation, according to the type of trigger, and whether we are doing a fresh or a frozen transfer. So basically, earlier we were having a standard luteal support, but now we have to understand that it also depends upon the type of trigger and the response to the stimulation. So therefore, broadly, a hyper-responder would require progesterone and HCG, but with caution. A normal responder would require progesterone plus HCG, and a poor responder can definitely be given progesterone plus HCG. She can also be given some amount of estrogen, but estrogen doesn't seem to be helping any of the responders very much. In frozen cycles, on the contrary, estrogen is mandatory, as we all know. Progesterone and HCG, all of them need to be given. In frozen cycles, there is a query to the HCG, but now new findings are suggesting that HCG helps in implantation as well. So there is no harm in giving one bolus HCG somewhere after 5 or 6 days of the embryo transfer. So that kind of a thing is also going on, but this is not routine that you have to give HCG in these patients. However, in these, you have to be selective and give it with caution. So the take-home message is, after doing so much of jugglery with our gonadotrophins, with the GnRH agonists, with the antagonists, so in doing all this kind of jugglery, we have come to the conclusion that increasing the oocyte yield will increase the chances of pregnancy, but only to a limit. And higher yield may actually lead to complication and eventually abnormal embryos. The goal is to achieve 15 oocytes by individualizing the therapies. And the type of drug and stimulation actually influences the quality of oocytes that you're going to, embryos that you're going to have. And the quantity is therefore overruled by the quality to get better pregnancy rates. And most importantly, you have to understand the art of COH. You have to understand the ovarian cycle and it has been defined by various subtypes now within the WHO types. So you have to understand that we have many, many types of women now who have to be individualized and treated according to what we are seeing in front of us. And it extends not only to the selection of the protocol, but also to the selection of the trigger and the luteal phase. So monitoring of the ovulation cycle or the controlled ovarian stimulation monitoring is also an art, because it will help you to decide the trigger, it will help you to decide the luteal phase. Therefore, a proper cycle control actually gives the best result. We have come a long way from just the simple long protocol or the short protocol. We have actually evolved and come a long way. We are using very, very complex therapies now in order to give the best results to our patients. With that, I thank you all very much for being here with me today. I hope I have been able to put across a little bit that would help you. Thank you so much.
Thank you so much, ma'am, for such an awesome lecture. Ma'am, we are getting lot of appreciation. Thank you so much, ma'am, for enlightening all of us.
Thank you.
Yeah. Ma'am, only appreciations I am able to see, no questions. Such
So
a
it
beautiful
was
lecture, ma'am.
quite a basic talk. I think there shouldn't be
No,
much.
no, ma'am. No, ma'am. What very elaborately, very nice lecture taken. Vaibhav, can you please check on the YouTube and Facebook if any questions are there? And there is one question has come. Ma'am, Dr. Chinmay is joined from Africa. He is writing in the dual stimulation. When do you do ET when?
Dual stimuli. Okay.
Hmm.
Uh, Very interesting. Actually, it is recommended that you are not to do it because you're starting it in you're doing a second one in the luteal phase also. So the endometrium is, we are not even bothered about the endometrium in that. But let me tell you, we very recently, what I did was, there was this patient who had to go back to the UK and she was there. She came to us during the luteal phase, and we actually did a random start in the luteal phase. Then she had a period and we did a regular one in the follicle. So it was a dual stimulation uh, in terms of definition. We did it twice, but in two different cycles, one after the other. In that patient, we could do a transfer, because then the second stimulation, immediately after the first one, we started one in the luteal phase. Like I said, late luteal, early luteal, we can start stimulations like that as well, and then go on to the follicular phase. So in such patients, yes, you can transfer. But if you're doing a duostim, that means follicular phase followed by luteal phase, no, you cannot transfer. You cannot.
Thank you, ma'am. Ma'am, there is one more question from Dr. Iglo. He is asking what is single dose of FSH?
Single, sorry?
Single dose of FSH. What is single dose FSH?
Oh, he's talking of the colitropin alpha. Yes,
Yeah,
we
yeah,
haven't talked of the the new drug in that. Yes,
yeah.
this is something which is going to come up, which is not yet, we don't have it available in India, but yes, it has been tried and the trials have come through. It will be, I suppose it was supposed to be available for everyone in this year, but now because of the COVID, it has gone back. This is something which you are going to give once a week, and you just monitor the patient. If this once a week dose is enough, then you don't need to supplement it by any more FSH. However, and of course, you have to continue to give the antagonist the same way as you're giving in this. However, if the one dose is not enough, then you may have to supplement it with one or two injections of FSH. Otherwise, one dose is quite enough to produce follicles. The other new drug which I didn't talk about is kisspeptin. That
Yes.
is another one which is going to come up very soon. It is again available it has undergone the trials, and it is a very good. We will see it as the fourth form of trigger now. We have three. We have we have the dual trigger. We have GnRH agonists. We will soon be having the kisspeptin, which is again a very physiological trigger. So let us see, with these two drugs, we may further. Actually, the advantage of these two is that basically the discomfort to the patient will decrease. One tablet or one injection once a week, and that's it. So the patient is not going to be so much discomforted as they are today. That is the advantage of these.
Yeah. Thank you so much, ma'am. Ma'am, Dr. D. Kinney has joined from UK.
Hello,
Sir
Dr.
is right. Yeah, sir is right. Sir usually attend my most of the webinars.
Oh, Dr. Kinney,
Yeah,
very
yeah, yeah, yeah.
nice to
He's
have
right. Yeah, he's writing. Dear Dr. Sonia, thank you so much. Very educated. I also want to point out that the dual trigger is also useful in empty follicle syndrome.
Very important, yes.
Yeah. If you do not get an egg after three of the follicles aspiration, give a second trigger and go for oocyte aspiration after 24 hours. What's your comments?
Absolutely right, Dr. Kinney. It is very, very important. And now what has happened is that is why people have gone a step ahead. And when we are giving a GnRH agonist trigger, we sometimes people give it to avoid. We are giving it to avoid the ovarian hyperstimulation. But on the contrary, what happens is we get more empty follicle syndromes in that rather than with HCG trigger. In HCG, it is generally a false kind of an empty follicle syndrome because of the drug problem and because the patient has not probably taken the injection properly. But here in GnRH agonist, of course, this also could be the cause. But what happens is that majority of the times the LH surge has not risen, it has not gone up, and therefore the patient ends up with a empty follicle syndrome. And I did try to explain that you do have to supplement it with another, either you give another trigger, not of GnRH, maybe HCG, but yes, you may be able to give another GnRH agonist trigger if you have taken the LH levels 12 hours after giving the trigger. And if the LH levels were more than 15, 12 hours following the GnRH agonist trigger, then you can give another GnRH to produce an LH surge and go ahead and retrieve the next day. So that can be done. Definitely, you're absolutely right, Dr. Kinney.
Yeah.
Yeah.
Thank you. Thank you so much, ma'am. Ma'am, there's one more question from Dr. Arnav Raman. Dr. Arnav is asking, what are the chances of PCO patient with dual trigger if one ovary left due to bad position of the ovary? What are the precautions we should take at the time of the post ovum pickup? It's written
What he
something like
means
that.
what he means to say is that if you have, but why would you want to give a dual trigger in this patient?
Same
You have
I
probably given a GNR, whatever trigger you have given. Basically, the worry is that if you are not able to retrieve the eggs from the second ovary, and the patient actually extrudes from that and has, she has follicle rupture inside her tummy, she's going to have a lot of pain. And God forbid, if you've got about 16, 17 follicles on that side, the patient is going to go in definitely for a big problem. So this is actually a bad management of the cycle, I would say. It should have been seen much earlier. And basically, if you felt that the follicles that this lady is producing are much more than what are required, then the step down should have been done. The follicles, a step down protocol needs to be done. And maybe if you think that you will not be able, suppose there's a very big endometrioma also sitting over there, or a very big fibroid, and you're not going to be able to approach the ovary, then in a PCO patient, you really need to be careful, because she may end up with very bad ovarian hyperstimulation and you won't be able to do anything about it. Having said that, please try to attempt abdominal retrieval then in such patients. Don't leave them like this. If you can't do a vaginal retrieval, try to do it abdominally so that you are able to empty that ovary as well before you actually say that everything has failed. That is my suggestion to you. But cycle management should be much more proper in such patients where you are anticipating this risk.
Thank you so much, ma'am. Ma'am, Dr. Egwillo has joined from Africa. Baba, can you please unmute him? He has raised the hand. He want to ask some question. Vaibhav, can you please unmute him? Dr. Egwillo? Rest lot of appraisals we are getting, ma'am. Thank you so much. Dr. Egwillo, if you want to ask the question, you can ask. Raise the hand.
Raise his hand.
Yeah.
Anyway.
Okay, ma'am. Anyhow, no more questions we are having. So thank you so much, ma'am, for enlightening all of us.
Thank you very much. Thank you very much, all of you, for having me here. God bless you, and I wish you a very, very happy Diwali. Wish you a very happy Diwali and
Yeah.
festivities ahead. God bless you. Keep safe. Stay at home.
Yeah. Thank you. Thank you, ma'am. Thank you. Thank you so much, ma'am.
Thank you
Yeah.
very much.
Yeah. Bye-bye, friends. So we are winding up here for today. Happy Diwali to all of you in advance. And please log in. In next week, we are having the special sessions on Wednesday and Thursday instead of having on Saturday and Sunday. Wednesday, we are having Dr. Pai sir with us with a very important topic, how to increase the success in the IVF cycle. And on the Thursday, we are having Dr. Nandita madam with us. What is the mystery of recurrent pregnancy loss? So, yeah, thank you, ma'am. One more doctor is saying, congratulations, Dr. Emily has joined from Nigeria.
Thank you so much,
I-
Dr. Neil.
yeah,
Thank you.
yeah,
Thank
yeah,
you so
yeah.
much. Bye-bye.
Thank, bye, bye. Thank you, InnovaCare Life Sciences too.